Hello, everyone. I hope that this day finds you well. Wait for a few more people to hop on here. Did everybody get in their exams? They were due today before class. Hopefully you had no problems on that one. I didn't receive any emails, which is always a good sign. But please feel free to stay after class if you have any questions or concerns. Wait one more second here. Take attendance. Alrighty, we have a couple more people joining in. Okay, everyone. All right, let's dive in. So today we're going to be covering joints of the upper extremity. This one's a pretty cut and dry presentation. It's set up similar to our lower extremity. So if you remember that from a couple weeks ago. Now with this one, I will kind of feed in some different stories, applications, injuries, all that fun stuff whenever we're covering that specific joint, just to again apply the anatomy to the actual function and what you might see depending on what profession you go into. We'll do some wrap up at the end as well as talk about what's due next. Afterwards, other than that, if you have any questions, unmute yourself, but I can actually see you this time, so hopefully that won't be an issue that we had last time. All right, so here are the joints that we're going to be covering. Obviously, similar to the lower extremity, but we have a lot more going on in the joint itself of the shoulder, and we'll get into that here in a moment on what's going on there, but we'll also unpack some different joints and what can happen in that area. So a lot of us don't really think about it, but there's a joint right here at your sternum. So you have that nice long bone right here in your chest, right where your quote unquote collarbones join in to your sternum. That is a joint. It's actually synovial because it does have movement there. We don't really think of it that way, but it does. You have a joint capsule and you have some ligaments protecting and keeping it where it is, as well as a cartilaginous disc. Remember, that's for cushioning, that's for padding, and that's for lubrication. So functional wise, remember I just said it does move. We don't really think of it as a movable joint, but it does. And it actually has movement, especially whenever you reach your arm overhead. So you can palpate your own SC joint and feel the movement as you reach your arm overhead. You will feel that. The closed packed means that it's the tightest the joint can get. Open means more loose, more actually susceptible to injury. But whenever you fully flex way overhead, you really feel it jam in, okay? What that basically says is that it's a little bit more technically protected, but I like to argue at that because just because that's protected, usually the shoulder is up for game. So has anybody ever heard of a burner or stinger? You've probably watched football. If you have, you've been like, oh yeah, he got a stinger, or he's like, oh yeah, I feel it all the way in my fingertips, or something of that nature. Literally it's called that because they feel a burn or a sting down their arm, or it just goes dead, right? So dead arm syndrome, okay? So with the burner stinger, that's the brachial plexus, which is this wad of nerves that comes out of your cervical and down. You have this injury that occurs due to either traction or compression of that bundle of nerves. So think about it if somebody grabs an arm and just straight up pulls, or if they get smashed and hit, like say in football, you take a helmet to just right here, yeah, that's gonna hurt. And it's actually felt all the way down the arm, okay? Deadman syndrome, seen a lot. Same mechanism, it's just that whole arm. So the burner stinger, it probably will travel right here. It's called the whole arm, where it just goes dead and it just like goes heavy, and there might be a little bit of stinging if it goes all the way down. The burner stinger, truthfully, we even call it that if it goes all the way down because there's more of that feeling. The dead arm is more of like, it's just, he can't lift it up, it's just done. So that's always interesting. And you'll see guys on the field just kind of shaking their arm or holding it or something weird because they're like, okay, this doesn't feel normal. I'm just getting a lightning bolt all the way down. Colt McCoy had this injury. The athletic trainer, removed him. He couldn't go back on because of this injury because it actually placed him at even further injury risk. So they were able to, hold him off. The coach was not very happy about it, but I always use that one because it was very notable, but it also shows my age. So maybe I need to update that one. But if you go back and you look at that injury, I kind of put that link there. It's very noticeable. It's you can just see his mannerisms. You can just see it in his face. And he was frustrated, but he needed to sit that one out. So then we go into the AC joint. So we just covered the SC joint. Now we're going more lateral into the AC joint. I've had several of my football kids get this injury in this area, so this will be a good one. Synovial, it's a plane joint, but it doesn't have an axis. And then of course you have that joint capsule major ligaments. And make sure that you check out these ligaments because they will play into the injuries that we'll discuss, okay? Those are probably ones that you'll need to know, both for my class and for future classes. And of course, we have that cartilaginous disc for protection and more. Okay, so these guys, it has a lot of movement, and you can kind of play around with it, especially if you have a bony collarbone. You can kind of play around with it. There's a little bit of joint play there, and depending on if you are lax in your ligaments, that will be affected. So gliding occurs in all directions, up, down, left, right, all those different ways. Hopefully not too much, because those ligaments are supposed to help to strap it down. That's what they're there for. When we get a little loose in there, that's whenever the problems happen. But we can have sprains, because remember, just like we sprain arm, ankle, we can sprain the ligaments in this joint. And it's called several different things. You'll hear it just, butchered every now and then. But shoulder separation, because you see that gap. You see the AC separation, again, because you see that gap. Guess what? Separated shoulder, because you see that gap. We try to grade it from 1 to 3. Just because, if it gets to the point where especially 3, we might be looking at surgery. And I've actually had a couple kids with this. So grade 1, I'm just kind of list it through. I shorten the ligaments just so that you don't have a mouthful, but it's going to be AC joint or AC ligament, CC ligament, and then CA ligament, okay? AC ligament is partially torn with a grade 1. The other ones are just fine. So it's kind of like with the spondies that we discussed, it slowly gets worse. Same here. Okay, so there's no joint disruption and just the AC ligament was affected. Now with a grade 2, we actually have a completely torn AC ligament and then partially torn CC ligament. With that, The CC ligament really only gets tainted, if you want to call it that, tainted, whenever that AC joint is completely torn, just due to how they lay. This guy will have to go in order for the CC ligament to be partially torn. CA is still there, and then you have a little bit of placement of the joint. And what that means is you see this little bump right here. You're going to see that prominent, like that gap start to take place. And you might be able to feel the grade 1 a little bit if you're really, really skilled and you palpate bilateral and they were fine beforehand. But this one, you're really going to start to notice the difference. And then, of course, once we get to the grade 3, that's bad juju, right? That means that you have 2 completely torn ligaments, and then you have that CA ligament intact. However, there is a complete displacement of the joint. So you can see how it pops up quite substantially, and it's just not fun. So with these guys, again, it kind of makes sense that as you go up in grade, you're going to have more of a problem, more of a complication, more of a longer return to play, okay? So this might be something that they do. They might rice it, then they might sling and rehab it, then they'll discontinue a sling, restore the range of motion, and then restore the strength. So that's not even talking about restoring balance or perturbation or plyometrics to the upper body. It's just getting them back to function. And then return to play, when can they take a hit? Which again, will go back to, have they been able to do their plyometrics? What sport do they play? What position do they play? So all of those factors will play in. But you can see here, it's going to be about 7 to 10 days before we're like restored back to functioning and we can really do sport specific stuff. Then grade 2, we're looking at 20 plus days. Same stuff is going to happen. It's just going to be slower because now we have 2 ligaments that are compromised. Guess what? Return to play. When can they take a hit? When are they back to sports ready versus just function? Then, of course, grade 3, we're hoping that they are just able to rehab appropriately. Some end up having to have surgery, but usually that's your older populations, or somebody who didn't rehab properly. But this is going to be 4+ weeks. So we're looking over a month, probably closer to a month and a half, definitely into 2 months before they're really game ready. And of course, once everything is torn, like all 3 ligaments are just gone, chances are they're going to need a reconstruction surgery. And it's kind of like a loop-de-loop, like you see here in the pictures. They drill some holes, they thread some stuff through, and they kind of clamp it all down. And then the goal is to have those ligaments restructure, reheal, scar down, okay? A lot of times, a surgeon will kind of go in there and poke holes in the ligaments, which sounds bad, but it stimulates more healing and to help them regrow together. But we see that quite a lot if we've just blown the whole joint. Any questions about that one before I go on? Okay. So moving on to the big daddy. The glenohumeral joint, this guy is our big shoulder joint. So all the movements that we can possibly make, the shoulder is the most mobile joint in the body. It has so much mobility. But with a lot of mobility comes a lot of a risk for injury, okay? So you have your joint ligaments that make up your capsule. You have, that cartilaginous disc, except this disc is a little bit special because just like in the hip, you have that acetabulum and then the hip labrum, you have the same thing going on here. Except remember my analogy about how the shoulder was more like setting a golf ball on a golf tee. So it's a little bit more susceptible, a little bit more like a big gust of wind could probably blow it over. Remember that? So this labrum, even though it does cup over, it's still a little bit more shallow compared to your hip, okay? So it cups it in there, but not quite as well as the hip socket, which opens it up for injury. You have a buttload of movement. So of course it's going to be diarthrotic, right? This baby can go roll, spin, glide. It just does all the things, right? Just throw the book at it. But there's a bunch of things that we need to consider whenever we're talking about this. And specifically, it gets its own plane. So right here at this joint, we have something called the scapular plane. And this is about 30 degrees forward and front to the side. So that means adduction, and then flexion, okay? And whenever you have a movement in that plane, we call it scaption, okay? A lot of times you will start off rehab in the scapular plane because it's a little bit easier, and it kind of takes out some of the tension out of the joint, and you're able to get a lot more function there. Now, your humerus and your scapula have a rhythm similar to, it's kind of the same as what we talked about, the lumbopelvic, the femoral pelvic, all those things that happen whenever another thing happens. We see that here. So usually we do this in class, and I encourage you to your significant other, kid, friend, have them stand with their back towards you and raise their arms overhead. And I want your hands to be on their shoulder blades and watch what happens as the arms go up. I'll try to send you a video just so that you can see it, just in case you don't have somebody in your household to play with their shoulder blades. It's kind of a weird question to ask, but trust me, it's cool. Whenever you move your arm overhead, your scapula moves in a special rhythm, okay? And this is a way that we can tell if the unit as a whole is functioning properly or if something's injured. So let's break it down in phases, okay? So phase one of about 0 to 30 degrees of abduction or adduction. Goodness, I'm gonna flip that one every single time tonight, apparently. So adduction to about 30 degrees of the humerus, so you're taking it out laterally. You're gonna have of the clavicle, so that's your collarbone, a little bit of elevation. This helps to allow that humeral head and everything to clear, plus the muscles, ligaments. So I know this is gonna be a lot of things, but try to picture it in your mind. So for this on 0 to 30, we have a 1 to 0 rhythm to keep track of. Then whenever we reach the 30 to 90, so we're coming up to shoulder height, you've abducted about 40 more degrees, right? But then your clavicle elevates 30 to 36 degrees. And then your scapula on the back side, so your shoulder blade, is gonna start to abduct, or adduct. I told you I'm gonna mess this up every single time tonight. Adduct. So whenever you have that adduction, that means that it's moving away. It's going to need to do that to, again, help to assist that arm to reach overhead. So now we're to a rhythm of 2 to 1, okay? So now with all the way overhead, you have more movement through the clavicle and scapula. Your scapula is going to abduct 30 more degrees, adduct 30 more degrees, and then also, abduct 30 degrees, and then clavicle is going to elevate 30 degrees, okay? The clavicle is going to posterior rotate. And that's something that is really weird to people. But what that means is that your collarbone rotates. Because remember we talked about sometimes there's a roll or a spin or a glide within the joint socket. Right here, it actually gets to roll around and spin around for you. And that happens about 30 to 50 degrees, okay? So I say all that to say this. If you were to look at somebody's back, as they're reaching those arms overhead, you're going to see movement through the scapula, through the shoulder blade. So it should, if you can see my hand here, you should see it to go up and out, maybe a little bit forward, okay? If it does not, so I repeat, if it does not, that means that there's a hiccup in the get up. There's something in that shoulder joint, the muscular system around it, that's not working appropriately to allow that movement to happen. Usually what it looks like is kind of a stutter. On some people, it's a lot, it's like noticeable. You just like see the scapula stuck, bam, and then it goes out. Or some people, it's like a little stutter, and it's like, you can see the scapula is wanting to move, but it's like, it's just not smooth. You should see that smooth movement. So again, just if you get a chance, practice on somebody, just see it. Some people have more dysfunction than others, but it's always really interesting to see. So I just talked about how these muscles in the shoulder, there's what, 11 plus that we worry about. The rotator cuff muscles themselves are actually only 4. And these are the ones that actually provide the stability to that glenohumeral joints directly. There's a buttload of them that's provided indirectly, but these guys are directly providing the stability. It helps to internally and externally rotate at the GH joint, and then provides that scaption movement. So it provides that nice 30 degrees abduction and flexion. Okay, any questions about that? The 4 muscles are supraspinatus, infraspinatus, teres minor, and subscapularis. Please note right here, so it's a group of 4, teres minor, because there is a teres major. Always gets you every time, okay? So teres minor is a part of the rotator cuff, teres major is not. The only difference between these guys is, what it directly innervates, where it's attached to, but then also the difference between minor and major, guess which one's bigger? The teres major is bigger, but the teres minor is smaller and it's kind of up underneath, okay? So just again, for our purposes here, the rotator cuff has 4 muscles: supra, infra, sub, and teres minor, okay? Any questions? And just to clarify, the supra is on top. So think of like your superiors. Infra, that's actually on the underneath side of the spine of the scapula. So infra, your inferior. Teres, that's just what I said. It's kind of hooked up underneath here. And then the subscap is underneath the scapula whenever you're looking at it from the backside, okay? So again, it's underneath on the back side of the scapula as you're looking at it from the back. All right, labral tears. Has anybody here ever experienced a labral tear in their shoulder or known somebody? If you do, drop it in the chat. I'd love to hear about it. Because these are pretty common, like I say, especially in sports, but not even in sports. If you're dealing with somebody in construction or a mom who picked up her kid wrong, I mean, multiple different things can happen here. So Braden says that he has, Justin said he knows people. It's very common. And I'm curious, Braden, did you get yours fixed by surgery? Or is it just there? I'll let him answer.
I'll just talk. Yeah, I tore my labral muscle in football my junior year. It was by like lifting weights, and they did surgery on me, and they put like a bar, I think it was, in my shoulder, and I have like 4 incisions, like 2. There's 2 in the front and then 2 in the back.
Okay.
But
yeah,
that's what happened to me.
For it?
Did I what?
Did you do rehab for it?
Yeah, it was 12 months. It was like, yeah, it was a year. So
it's a long one, and it takes it takes a lot of patience and to rehab both as a patient and as a clinician, because there is so much movement in that joint. And can you speak to the fact, it's a lot harder to use your limb, or not use your limb, I should say, and you realize how much you use. Yeah. And you use it almost too soon. It's like, oh, it lets you know, it's.
Yeah. My doctor, they actually, when she first told me, like right after I got a rehab, she's like, don't push it, because she's heard of people that have pushed like right to it and started weightlifting again, and they retore their shoulder right after they got out there. So.
And it's so common. And
yeah,
we'll
it's
talk
a long
about that.
process.
Yeah, it's a butt pain to rehab and have. So let's talk about a little. It's called a slap tear. With a labral toe, you can have a slap tear. This means a superior labral anterior posterior. That means, that's a long way to say that, superior portion of the labrum, you have a tear anterior posterior, which means like agir. So what that means is it could be a bucket handle tear like you see here. It's kind of like you have a handle torn off of your labrum. That's bad news. All of it's bad news, but this one's aggravating because you'll feel that catch every time you move your arm. It's like a pinch. It's so aggravating to so many people. But you also have like, now let's talk about injuries for a second, how you get it. Fouche is called, it's a fall on an outstretched hand. So that means, you know, you're trying to catch yourself as you tripped off of the curb. You're trying to catch yourself as, you know, X, Y, Z. Usually in, you know, maybe football, they get hit and then they reach out the hand, or they trip and they reach out that hand and it just jams the socket. You kind of see that shoulder pierce up to the ear really quickly, and there goes the labrum, okay? And then also a peel back, and sometimes that just means you got grabbed and literally your arm rotates and it peels back and it rotates through. It hurts. It's, there's no easy way to say it, it hurts. These you usually know that you have. Why I say that is because there's usually a mechanism of injury that lets you know. The only way that that's not is if you're hypermobile and you just kind of caught it wrong, and that's a whole nother topic. But you can also have a Bankart lesion. So that means deep inside that labrum, you have what is right here. You see, like, see my cursor? Hopefully everybody can see it. Whenever you had that bucket handle tear, it was more on this upper, right? That superior aspect. But with a Bankart lesion, it's more in that anterior circle, right next to the concave surface where your shoulder actually sits in, or your humerus actually sits into in the shoulder. This is another one that, again, you're going to be going in there surgically to kind of repair that, hopefully stitch it together. But, you know, Braden said, whenever you have these surgeries, you have a high risk of re-injuring because it doesn't take much whenever there's not a lot of support there, unless you're talking about your muscles, which will be impacted by surgery as well. But you see that traumatic experience to that joint, and it takes a while to heal. And it's just, it's not a fun game. So impingement and instability. Has anybody ever heard of shoulder impingement, or I have a pinch in my shoulder, or something of that nature? Maybe you felt it, like you reached overhead and you were like, oh, that hurt, kind of catches you. Impingement is kind of a catch-all for, okay, something is out of balance in my muscles. And why I say it that way is because you see with my cursor, there's this subacromial space right here. So you have your acromion sticking out, humeral head going in. You want that humeral head to centrate within the shoulder socket. What that means within that humeral joint, you want that bone to be in the center of that space appropriately. You don't want it to travel too much superiorly whenever you reach your arm overhead or go down, and same way anteriorly, posterior, or inferiorly. So it has to kind of have that happy space. It has to be able to move inferiorly whenever you reach up so that you clear your bones on top, as well as your ligaments and all that gets to clear everything, but then also kind of slip upwards as you go back down. And you can almost feel it in your own shoulder joint as you move your arm around. And it's kind of like peanut butter and jelly, love and marriage. Whenever you have impingement, you're going to have instability within the joint, because that just means that the shoulder itself is not stable, it's not centrating properly, and we have bad juju. So instability, this is issues in the tissues, okay? It's a lack of joint control. That just means that that humeral head is just going crazy all up in there as you're reaching that arm overhead. It doesn't have that true smooth transition. Your scapula probably doesn't as well. And you can't maintain that articulation within the joint socket, okay? That's really, it stinks, it's annoying. And a lot of individuals, they just, it just gets annoying, that pain, that nagging catching. And a lot of times that can lead to things like slap tears. It can lead to things like those lesions, just because that humeral head is not congruent within the space. It can also lead to some tension, some tendonitis, tendinosis, all that fun stuff within the joint. So it's really important to take care of. Any questions with the glenohumeral joint? We discussed a lot of different injuries. I see some. How are we understanding these concepts? Put in the chat box. 0, I have no idea what I'm doing. 10, I'm a gold standard. I know exactly what's going on. Everything makes sense. Okay. I'll take 7 and 8s. That's not bad. So what I want you to do, and as we kind of go through here, do this with the rest of everything, go through, look at the different joints, because you will see them again. Later on, whenever you're in anatomy, you know, they'll be referred to. So the more that you can understand these concepts, the better. For the exam, make sure that you know if the joints are what they are structurally, but also functionally, okay? Those are 2 things that you need to know. Most of them, you don't need to know all the ligaments, but that's a bonus. But definitely know structural and functional. All right, so let's go into the elbow, the ulnar humeral joint. So everybody kind of just stand in an anatomical position. You probably remember that your palms are forward, right? So hands down. Remember which one is the ulna, which side? Somebody tell me which side of your forearm holds the ulna. Where do you see that resting? We don't have Joseph here, so y'all got to pick up your slack here. So if you're standing like this, which one is the ulna? The one that's towards your thumb or the one that's towards the pinky?
It's towards the thumb, right?
So, anybody have a gander on which one it is?
Is it towards the thumb?
Towards the thumb. Anybody back him? Y'all are so quiet. So, if you think about it, and I'm trying to pull up something on my phone to maybe show you, because sometimes it's hard to pull it up. Here we go. Might be a little bit. So, everybody see this? So the ulna is under. 50-50 shot. You were close. Ulna under. Think of it that way. Ulna under. That's how I remembered it. Not exactly the most pretty way to remember it, but ulna under. That's how I got through grad school. Ulna under. And that guy is, it's kind of a neat bone. You see it here where it goes into our elbow joint. You see it here. So we see it's kind of like a lock and key mechanism. On the back side, on the posterior side, you have that bony part. Whenever you see my elbow right here, you see that bony part sticking out towards you. It's a process. Sticks out, hooks into the humerus. Because there's a little divot on the back side of the humerus that it kind of actually pivots into. Okay, and so this is a really cool structure because it helps us find that end spot in extension. So whenever we flex the muscle, the key is out of the lock, and then whenever we extend out, we see that bony prominence kind of hook under and in to the back side of the humerus, and you feel that end range of your extension. Okay, so structurally it's synovial. It's hinge joint, which makes sense, right? And then diarthrotic. This joint right here, you see the MCL, the UCL. This is known for Tommy John surgery. So the UCL, underside UCL, ulnar collateral ligament, okay? It's well known, the Tommy John surgery. It's named after, guess what, Tommy John. And this baseball player has become notorious for going out there and saying, guys, you should not be getting this just to get it. Don't be getting this surgery, be preventing, because it became popularized to get the Tommy John surgery as a pitcher because the pitchers came back better after the surgery. It's a long road, but a lot of times they felt stronger. And the only reason was, guess what? They did the work. They did the rehab. And so they felt stronger because guess what? They were. So they use this something called the docking technique here. And they just strapped it down. You can see that right here. See how they just wire it in? So that is basically your faux UCL joint. And then you can dislocate it. That's just painful, right? It looks brutal. The upper extremity, you hope it doesn't do this, because as far as on my side, you hope that this doesn't happen, because guess what? This really needs to be relocated. And that just means that you're really yanking hard on the forearm, hoping it slides into place and does not catch any nerves or arteries along the way. And yeah, there's just a nice little pop, and you hope that you didn't catch anything else. But this is an x-ray from a gentleman who did have such an unfortunate event. You could see how this would be a fall on an outstretched hand with maybe minorly flexed through the elbow, opening up that joint. Yeah, bad day. But that just means that goodbye to all those ligaments and that joint capsule right there, and they have to recreate that. Any questions on that? So look up the Tommy John surgery if you haven't already. It's kind of interesting. There's a lot more about it coming out right now that I found interesting. Maybe do some research on your own. But now we're going to go to the radial side. So the radius on the side of the thumb. You have a synovial joint, pivot joint, because the actual top of the radial head is kind of that spin that we see up here on the collarbone, the clavicle. You have an ulnar ligament, and you also have a cartilage space there. And it's diaphragmatic because it does a lot of supination, pronation. So you see my cursor right here? You see how this is kind of a circle at the top? That basically rolls over the ulna continuously to do this motion right here, supinate and pronate. That action has to start up here in or be available at the elbow as well. So like I just said, there's the supination pronation picture right there. And it is synovial, non-axial. You have a joint at the elbow and then also at the wrist. So seeing here, you see that rotation happening here and down below. I have to fix something, 1 second. All right, sorry guys, the problem of being at home, you see things coming in that shouldn't. All right, so again, it's gonna be proximal and distal. And what you're going to see is the wrist and hand is a bunch of bones right here. I'm not going to make you memorize all of them. I'm not going to make you name them. You will do that in anatomy, but there's a buttload, trust me. You have all sorts of joints. I'm going to kind of briefly go through them here, maybe cover a couple of injuries. But there's a lot going on in your forearm and wrist and hand, okay? So you have the radial carpal and the ulnar carpal. This is where your forearm bones join and meet in at the wrist with those wrist bones, okay? They are both synovial. They're biaxial condyloid. If you flip back to those first few PowerPoints. I want you to review those to understand those terms. You have major ligaments that support them on both sides, MCL, LCL, and then also anterior and posteriorly. You have a cartilaginous disc there that is a complex. It's very important. Usually the times that you see injuries to it, it might be with arthritis, or say with, if you have a jammed wrist after a car wreck. 1 second, guys. I'm sorry. All right, sorry about that. Okay, so it's structural synovial cartilaginous disc. Like I said, the times that you see it injured is probably going to be something like a car wreck or a foosh where you fall on an outstretched hand, and maybe the wrist got it more than the shoulder, or both. And then also arthritis as it breaks down that cartilage aspect. Now, functionally, you have diarthrotic, which makes sense because you can do so much movement in this wrist, right? Left, right, up, down, circles. Yeah, you can do it all. And then within all these little bones, which I gave you the names here, like I say, I'm not going to make you memorize them now, but, you know, take a look at it. And there's all sorts of dirty nomenclatures to go over. You will learn them all later. And that you will have to memorize them. In my anatomy classes, you will have to memorize them. But they are synovial, so you can move them a lot. They're functionally diaphragmatic, and for some people, they can move more than others depending on how lax they are in the wrist. And then also if there's any arthritis or pre-existing conditions. Now, the first metacarpal joint, so that would be your thumb. Your thumb can do a lot of movement, so guess what? It's diarthrotic. And if you kind of take it for a joyride, you can just all over the place with your thumb. You do have major ligaments. This bad boy, you do not want to dislocate it because it is a just terrible surgery to get back together and pop it back into place and all the things. But it does a lot for you, and it can do a lot. So whenever you're talking about grip strength, shoulder health, you really want to make sure that that complex of the thumb, hand, wrist, that is fascially connected to the shoulder is nice and strong to protect it and save it from injury. And then of course, joints 2 through 5 through there, backing up to the carpals. There's a lot of ligaments. I'm not going to make you memorize them, but there are a bunch. So it goes to show that if you do injure this joint, it's going to take a while to heal. And then making our way, and you should be able to see my cursor right here, down to the metacarpal phalangeal joints. You have structurally synovial, diarthrotic, lots of movement everywhere. And then interphalangeal joints. These guys are little bitty, but again, you have a lot of movement. And I like to put this one in because there is a nice little flexure of, looks like the 4th met. You can see right there, a nice little transverse. And then let's talk about a few clinical applications before we wrap up. Some common injuries to the hands. You've probably heard of carpal tunnel syndrome. It's a pain in the butt for many, many people. And it's a lot of tingling sensations, a lot of burning sensations, okay? So it's a chronic inflammation injury. And it's the transverse carpal ligament right here can get hacked off tight, inflamed, and it'll press on that median nerve. But then also the flexor tendons down here can get, again, tendonitis, inflamed, and can press against that nerve. And then that's where you have tension that ends up putting more pressure on the nerve and causing the stinging, the burning, et cetera, et cetera. It's also common with wrist extension. So say if you have your computer set up poorly, mechanics poor on any job that you do, and you're stuck like this, you will see a lot of inflammation in this come to pass. This syndrome can be prevented with good mechanics, with grip strength, but it's seen a lot. And it's really frustrating for a rehab professional like myself, because if you get the surgery for carpal tunnel once, the risk of you having it again does increase substantially. So it's usually not a one and done surgery. And then jersey finger. This one's fine because it is the rupture of the flexor tendon. So up here, you have kind of this flexor tendon that inserts at the top of your hand. And it's kind of like if you play soccer and you're playing dirty and you kind of hooked your finger or hand into somebody's jersey to keep them from passing, and they won, and you pop that tendon, now you can't fully flex your tendon because that has been ripped off. That's how I remembered it, was jersey finger. It's kind of like you hooked your finger on somebody's jersey and their shirt won instead of you, and it popped your tendon off. It's really common to see. And then you have mallet finger, where you rupture the hood, the extensor tendon that comes just underneath where your nail is. And so basically you can't do this motion. If you see my hand right here, you can't straighten it all the way out. And it just hangs out in this funky little curve at the top of your finger. That one's really common too. And then gamekeeper's thumb, rupture of the ulnar collateral ligaments. This sucks because then you cannot do this. Can't bring your hand together. So you're trying to brace it, usually maybe have surgery to repair it. But it is called gamekeeper's thumb because think about a goalie who goes up and tries to catch a ball. Maybe it hits the thumb instead of the palm, and the force of that ball sends that thumb back. That's a lot of times where you'll see that rupture. Any questions with that? Because that was it. It's a lot of content.